Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Majerison here. Welcome to Top Med Talk. This piece is in 4 parts, and this is the first of them. It's called the Perioperative Cognition Workshop. It took place at the Australian and New Zealand College of Anaesthetists earlier this year. Please make sure you've subscribed to Top Med Talk. That way you'll be sure to hear parts 2, 3 and 4. Also, if you have a little look in the show notes, you'll find links to them as well. www.topmedtalk.com.
This is the Perioperative Cognition Workshop. I'm David Scott. This is Liz Everett. We're from St Vincent's here in Melbourne, and we obviously have a strong interest in this area. So we're going to be sort of trying to make it relatively informal and interactive. So what we aim to do is to run through there's a new terminology for perioperative neurocognitive disorders, which is going to replace POCD, post-operative cognitive dysfunction. We will outline how you can differentiate between the immediate acute phase recovery disorders, which are most common, of delayed neurocognitive recovery and post-operative delirium. And we're going to briefly talk about risk factors, but we're not really going to go into the academic side of that so much because we want to talk more on the screening tools for cognition and delirium and learn the basics of what they are, where they fit, and so on. So just to start off, to put it into context, and Carol Peden has been emphasising how you have to have patient stories, and these are real patient stories, and they're actually drawn from colleagues of ours, although we do get calls and emails from time to time. So this is an 82-year-old retiree who's living independently. He was the carer for his wife. He had hypertension, type 2 diabetes, he had a fall and fractured his hip. So he had that done under spinal with sedation. He had difficult pain control post-operatively, and he did have an episode or two of post-operative delirium. As detected by the family, he was agitated and restless. His son said to us his memory is just not the same. He keeps forgetting routine things. He's no longer capable of living independently, nor, importantly, also supporting his wife. And he can't adapt to changed circumstances. So he's had a real change in his ability to function independently. It's impacted on the family. It's impacted on his dependent wife as well. Perhaps more close to home, this is another colleague, a 54-year-old anaesthetist, fit, a good golfer, a very good golfer, no medical history of significance, obviously too much golf, needed shoulder surgery, had a GA with an interscalene block, was sitting, managed well, good pain control afterwards, but quite distinctly he described how for 5 days afterwards his mind felt like it was in a fog. He couldn't think clearly, it was in a blur, he couldn't concentrate for long periods, and then almost over a period of an hour or two, he said it felt, but suddenly it felt like it lifted and he had clarity of thought again. And now he seems to be fine. But even if his shoulder hadn't been operated on so he couldn't actually do his clinical role, he felt he couldn't have done any other clinical activities at all with his mind the way it was. So it is real and it is impacting people like you and I. But the problem is, this concept we've got of post-operative cognitive dysfunction, POCD, has neither specific symptoms nor a diagnosis. And we've created this problem for ourselves because POCD in the literature is a research diagnosis. It's made by applying this range of neurocognitive tests, testing a number of different domains of cognition. And cognition is really complex. There's a whole lot of different domains like executive function, attention, memory, other things, which we'll come to when we talk about some of the screening tests. I don't want to preempt those. So they do all these tests, which is fine, and we do statistical analysis on these tests and then apply criteria to say, OK, they've performed poorly in these tests compared to controls or compared to their baseline, and we call it POCD, and that's the way it's been done for 20, 30 years. Problem is, It's not a clinical diagnosis. So you can't say to either of these two people, you've got POCD, because that's not what POCD is. POCD is this lab test, this research test. Very useful, very sensitive, quite specific, but doesn't translate clinically. So we thought we'd do something about it.
That's the interrupting microphone.
Oh, okay.
Okay, so I'm going to talk a bit about the new nomenclature that we've been working on for the last 4 years. It was published just last week in 6 journals, which I'll come to in a moment. The reason for this is, as David has said, post-operative cognitive dysfunction is a research tool. It's a research tool, so it doesn't tell us what the clinical impact of that cognitive impairment that we identify with neuropsychological tests actually has in terms of clinical impact. So we worked with a group of multidisciplinary experts from around the world, the International Consensus Nomenclature group, and the thing we wanted to do was to find a recommendation for terminology and definitions and criteria that were consistent across medical disciplines caring for the elderly. So rather than being in a silo in hospital with some terminology and criteria that don't mean anything beyond the hospital, we wanted to come up with a series of criteria that actually are consistent with what's used in the community. And so we've published the recommendations for the nomenclature of cognitive change, and I'll go into that in a bit of detail. This was published just last week in 6 journals, all anaesthetic journals around the world, plus the Journal of Alzheimer's Disease. And I will explain what we did in terms of these recommendations now.
Can I just add?
Yes, you can.
Can I just add that this is the first time ever across that we've had this many simultaneous publications of guidelines in the anaesthesia literature, and quite likely it's the first time ever there's been 6 simultaneous publications across in any discipline for any guidelines or recommendations. This is a really strong and powerful announcement and set of recommendations, and it crosses obviously all of Europe and England and North America and Canada and USA, and including Alzheimer's literature. So it's worth having a read of it so you understand what's going on.
Yep.
Liz is going to run through what the actual guts of it is.
Yeah, and I think although it is predominantly in the anaesthesia literature, this is a group of experts across all disciplines that care for the elderly. So it is it's a starting point. There's 3 editorials associated with these publications, and if you're interested in reading those, what you'll see is that it's the start of a discussion, and we imagine that this will be a bit like a living document, and as we start to use the criteria, they will evolve. So we decided that we would base the recommendations on the Diagnostic and Statistical Manual for Mental Disorders. In the section looking at neurocognitive disorders, where the primary clinical deficit is in cognitive function. So the reason for doing that is because that's what's used in psychiatry, so psychiatry rely heavily on the DSM, and additionally these map so mild neurocognitive disorder maps to the National Institute of Aging Alzheimer's Association criteria for mild cognitive impairment. Major neurocognitive disorder maps to the dementia criteria. So we're using terminology that's consistent in the community, but we're using definitions and criteria that we can apply to our data. Importantly, what we're seeing with mild neurocognitive disorder is an objective decline of 1 to 2 standard deviations below controls or norms, and that's much greater objective decline in major neurocognitive disorder. The other thing that we haven't looked at when we've talked about post-operative cognitive dysfunction is a subjective impairment, and yet that is really important in the community. When people are diagnosed as having some sort of cognitive impairment in the community, either they or a family member saying that they have a subjective complaint that their memory isn't the same as it used to be is really, really important. So we now have that as part of our criteria. Similarly, function is important, and I'll show you some examples from some of our data in a moment. Whether or not the patient has a functional decline that is the result of their cognitive impairment is really important, and this takes that into account. For mild neurocognitive disorder, functional activities are maintained, but for major neurocognitive disorder, there needs to be a decline in function. So these are our recommendations. Firstly, what we used to call pre-existing cognitive impairment, which is when the patient is presenting for surgery or scheduled for surgery. We don't think that that needs to have a specifier that's associated with surgery. Just like the patient could be having a test as part of being in a research project, the patient could have gone to a memory clinic 2 weeks before their surgery, in which case it wouldn't have anything to do with the surgery. So we're saying that preoperatively we should just use the terms mild and major neurocognitive disorder. During the early acute phase of post-operative period, we think that we should be looking at delirium. It's been overlooked in a lot of POCD studies, but really we know that that's what's triggering longer-term cognitive impairment. It's got an impact on many outcomes that are poor. Morbidity, mortality is increased in patients, even following one episode of delirium. The other thing is that many people have looked at POCD from 1 day to 14 days post-operatively. This is a period when the patient is still recovering. We're thinking that probably, and certainly our recommendations from the group are that that's probably not a time when you want to do a full neuropsychological assessment on a patient. So we're focusing on delirium in the early post-op period. What we used to call postoperative cognitive dysfunction out to 30 days, we're now saying should be called delayed neurocognitive recovery to recognise the fact that those patients are still going through a physiological recovery as well as probably some sort of cognitive recovery. At 3 months and at 12 months, we're going to use the term mild and major neurocognitive disorder with the specifier post-operative. So we're saying that this cognitive impairment that we're observing is temporarily associated with an intervention of anaesthesia and surgery. Beyond 12 months, there's a number of studies, including our own, looking at POCD out to 7.5 years. Being able to say that some cognitive impairment at 7.5 years is associated with a surgery and an anaesthesia that occurred that long ago, we're thinking we need some more mechanistic studies and more information before we can make that association. So we're taking the specifier away. So beyond 12 months, unless it's not a new diagnosis, the terminology will be mild and major neurocognitive disorder without a specifier. Just very quickly, I wanted to show you the differences between post-operative cognitive dysfunction. So over here you can see the definition for post-operative cognitive dysfunction, and on the right these definitions for perioperative neurocognitive disorders. And I just want to draw your attention to the fact, as I've already said, that what wasn't required for POCD that is required for perioperative neurocognitive disorders is a subjective complaint, which is really important, and assessment of function. We're recommending that people use the instrumental activities of daily living, which are assessing something much more subtle than activities of daily living. So when you're looking at activities of daily living, and Dave Story touched on this yesterday, you're talking about things like bathing and dressing. When you're talking about instrumental activities of daily living, you're talking about something much more subtle. So can the patient still do their shopping? Can they do their banking? Things that are required for independent living.
Can I just add, just to mention that there is still a statistical, a diagnostic test in this. So there is the decrease in a cognitive domain using, we're not specifying what test to use, but in a cognitive domain, such as executive function or memory, of if it's between 1 and 2 standard deviations from either a set of norms or from a control group, it would be in the mild category, and if it's greater than or equal to 2 standard deviations, deterioration compared to your normal group or the control group, it would be major. Yep. So there is the cognitive testing is still very much in there, but we're not constraining to the type of test, the specific test you use, but it is to embrace a domain of cognition. Yeah, so it's slightly less stringent than the criteria for POCD, which was 2 tests out of a battery of 8 to 10. So just to give you an idea of how important this is some data from our cardiac study, the RECOGNISE study, 76 patients at 3 months, and what you can see is that 2/3 of those patients have a subjective complaint that their memory isn't the same at 3 months post-operative.
So we were missing that entirely looking at POCD. We didn't even ask the question. So we have anecdotal reports, but we don't actually assess, well, we weren't assessing subjective complaint. Similarly, really important, nearly 2/3 of patients have a decline in their instrumental activities of daily living at 3 months post-cardiac surgery. So what we're seeing using the new terminology is actually the clinical impact on the patients, and this is significant.
Top Med Talk.
Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.